So I think I'm recording now. Okay, so what I'm going to do tonight is just kind of elaborate. You know, the subject that you've been studying is violence, and I'm going to do a portion of the suicide portion. Okay, so what are our objectives? We're going to identify the risk factors of the patient who may be suicidal, discuss demographics that may present warning signs to suicide, and apply the nursing process for suicidal identification, assessment, planning, implementation, and evaluation, and look into the 5 steps of evaluation and triaging assessment. So what is suicide? The definition: suicide is not a diagnosis or a disorder, but a behavior or the act of taking one's own life. So we're talking about the risk factors. When we look at the risk factors, some of them here, as you see, are marital status. We'll take a couple of them: gender, the age of the patient, and certain types of religion. So out of this group, and over here you have the socioeconomic status, ethnicity, race, mental disorders, and mood disorders. So out of this group, which ones do you think are the most likely to commit suicide?
Singles.
According to
Yeah, single marital status.
Okay, single marital status is somewhere in there, but that don't give you, it's not the highest risk.
Depression.
Would it be
Depression.
Would it be white man?
Schizophrenia.
I think I heard somebody say
White man?
white men. White men, most likely, and then you come back down there and get around to age. What about age?
Over 85.
Yes, older men. Why do you think with gender, if males and females, why do you think that it is so much higher in the older white males? Why do you think that they are more successful?
I mean, inspired on.
Because of what they use. Most of the time, the ladies use pills. They do have a chance to make it to the emergency room, but most of the time, the white men use firearms that they have available, and then it's over pretty much. Most of the time, the ones that you're going to get in the hospital are the ones on the right-hand side, the ones with substance abuse, your schizophrenia, your eating disorders, like the nice little video that we saw on last week. That really, I really learned a lot from that. Your personality disorders. What about occupation, family history?
Lawyers and dentists.
Yeah, high stress.
Huh?
High stress jobs like
Okay. Yeah.
nurses, doctors.
And we talked about that, didn't we? You see it here. Here we go right here with nursing. It's one of our higher stress occupations. So you guys make sure you take time out for yourself and don't let yourself get stressed out, because it can be a very stressful situation. A very stressful job. So let's talk about warning signs. Some of the warning signs that you're going to see, one at the top of the list, I have threats to harm oneself or end one's life. We have seeking access or means. If we're talking about the way that you're going to do it, that's a good sign. Excuse me, there. Expressing ideation of suicide, hopelessness. What's ideation? What does that mean? Excuse me. I was trying to turn the heat on. Get a little warm up here. Ideation means what? I'm like, oh. Thoughts. Yeah. They're thinking about it. Hopelessness, rage, anger, or seeking revenge, reckless, impulsive, or risky behavior. A feeling of being trapped. There's just no way out. That's all that is. That's all that I can do. withdrawal from family, friends, or society. And I think we had the perfect example of that with one of our students. Can you tell us a little bit about that? I was in clinical with you last week, and you had a perfect example.
Yep, so I had a patient who was 27, he had lost his job, and then lost his apartment, lost his house, he was homeless, and kind of just, he didn't have a strong social support because he had just moved to the area for his job recently, and his family was not being supportive of him. So he tried to commit suicide and ended up in our unit.
Yeah. What was his mood and affect like?
From what I understand, the day before I saw him, he was coming down from all of the meds he took, and so he was quite agitated and psychotic, I think. But the day I saw him, he was very withdrawn and like he wouldn't talk to me or look at me or, really respond too much.
So kind of from the other side to the other. Too much or too little sleep, dramatic changes in the mood, and definitely expressing no reason for continuing to live. All right, myth or fact? We've heard a couple of things. I'm gonna come bring a couple of these up here, and I want you to tell me whether you think it's a myth or a fact. Once a person is suicidal, he or she is suicidal forever. Yeah. The truth is suicidal ideation and risk fluctuate over time. Adequate support and resources may assure a normal life. They've got to have that support and those resources. Suicide is inherited or runs in families. Yeah. Family history and genetics may contribute to an increased risk for suicide. Children, and this is the one that kind of grabbed me the most because I didn't realize that it was that prevalent in children, but ages 5 to 12 cannot be suicidal. Were you all aware of that? I know somebody was telling me a story this weekend about a relative with around 12-ish that had attempted suicide. So annually, about 30 to 35 children younger than 12 take their own lives, and they're not all clinically depressed. So what method do you think the children use?
Suffocation.
Hanging themselves. Suffocation. To me, that's just really sad. It all is just really sad. All right, so let's talk about the plan of care. You have your assessment. You're going to be assessing that patient, making a plan for them. Then you're going to be implementing your plan, and then you're going to be evaluation, just like we do with everything else. Got the right one at this time. So when you're doing your assessment, you're looking for precipitating factors, what brought them there in the first place, any relevant history, what stage of life, did the losses or disappointments occur? If that's the case, is there a history of previous suicide attempts? How has the individual coped with the previous crises in the past? Looking at that with your assessment. And guiding principles to assess those risks, you want a detailed assessment and screening, identifying that each individual is has a unique situation. So we can't just put them all in one box and say, okay, here we go. They got to be an individual. They got to be individualized. We have to establish a therapeutic and trusting relationship through what? Empathy and respect. So what do we mean by empathy?
Understanding how they're feeling.
Feelings. I think I heard somebody say, walk a mile in my shoes. So you can actually feel what's going on. And respect as well. Use communication strategies to explore thoughts, feelings, and behaviors. Now, when we're talking about communication strategies, are we only talking about verbal communication?
No.
What about that body language, right? Very, very, very important. Do any of you have a specific body language that you use all the time, or anyone has told you that you used? Yes. Facial expressions. I can even see, I'm kind of getting used to the mask now. And some of the staff members that I work with, I tell them, you got on that mask, but I can still see your eyes. They say the eyes is the windows to the soul, right? A lot of times I can see your eyes and still tell if you're smiling or frowning. So, and we discussed as well, when somebody walk in the door, you kind of judging them from the top of their head down to their trunk to see what's going on. Usually patients that commit suicide, their thoughts are running really, really deep, and they're really, really sensitive at the time. So if you just kind of walk in the door, even though you're saying something that's really meaningful, if you give a certain type of expression as far as nonverbal, that's what they're going to pick up, right? And we don't want to do that. We have to be straightforward. All right. The assessment is ongoing because they're kind of up and down, back and forth, right to left, left to right. So we want to keep up with those different moods. Want to know what their support system is. Collaboration with the team. That's going to be a biggie because you need a whole team here. Certain people with certain philosophies, characteristics, evidence-based practice that can bring certain things to the situation. That direct language is very, very, very important. Don't beat about the bush with these folks. It's okay to say suicide. It's okay to say death because you want to be able to express what you really mean. You want them to be able to express to you what they really mean so you can carry out that plan of care. Do not attempt to discern the underlying message because it's not always what they're saying. A lot of times it's what they're doing. Consider cultural content of expression to recognize risk regardless of what religion, race, or culture. So, and when we're talking about and looking at culture, we have a lot of cultures now, a lot of different ways that expressions are given according to culture. We have cultures within a culture, so we want to make sure we watch that. Make sure you're documenting. Full documentation of risk factors, your assessment, what you did to evaluate, implementation, and make sure you're always documenting the response that you get. All right. We talked about those presenting symptoms of ideation, active or current with a plan. We know we want to escalate if they're talking about a plan and the way that they're going to carry it out. Substance abuse, mood altering drugs, purposeless, no reason to continue living, anger, trapped, hopelessness, withdrawal, anxiety, recklessness, anxiety, mood shifts. Okay, so anybody remember the acronym that we used last week to discuss this? Is path warm. Everybody got it right. There it is. Is path warm. That'll just sort of help you there if you're a person that like to use acronyms with your assessment. Good job. So now we want to work out those nursing diagnoses, right? So give me a couple. Risk for suicide related to hopelessness. A lot of our risk factors that we're working with. Hopelessness could be related to, a serious loss. A lot of times when we go back, your marital status is divorced, widowers, because this caused a drastic life change and they weren't able to cope with that. So your interventions, I need to ask you about that before I went to it. What are some of the first things you want to recognize and intervene with on your patients?
Escalating.
As far as safety.
Escalating type of behaviors.
Okay, even before then, as far as safety.
Making sure they have like nothing sharp on them.
Uh-huh. There you go. There you go. You want to watch them. Make sure the environment is safe. And what we mean by that, making sure there's nothing there. And they know how to hide stuff. Because I had a patient, he was really, he had a catheter for his treatment, for his dialysis treatment. I didn't know, sometimes you're just not looking for it. One of my coworkers went in the bathroom because he was acting kind of strange, and he had all kind of like spoons and paraphernalia, like hid in place. I would have never found him, but he told me he had the spoon in there, his lighter, all of that. But he was right there in the hospital, still doing that drug, injecting it in his catheter. Dangerous situation. So we ended up, sending them to psych and everything so they could really watch him. Ask directly about any current plans or means, and maintain that close observation. I know a lot of you have done your psych rotation and have seen that they have a sitter, a one-on-one. And during that stage, that is what we need. We don't need to let them get away. All right, be direct, talk openly. We said that matter-of-factly about suicide. Have to listen. What does listen actively mean?
Stop talking.
Yeah. And don't you hate it when you're talking and somebody just start talking and you still talking? Are they listening? No. And I got to the point, I got bored out. Are you listening to me? Because I'm still talking, but you just started talking. I have a bad habit of drifting. Anybody drift? Somebody's talking for a long time. But I had to recognize it. I'll drift, and then I'll come back and hear the last part of the conversation. Is that actively listen? No, it is not. But once you recognize, you have to recognize sometimes what you're doing. And that way, if you don't recognize it, you won't be able to change it. So I had to stop and recognize and worked on my listening skills. Encourage them to express their feelings, current crisis situation, help identify the situation, help them to know what we can't control, we can't really change, right? That's even us. Have the physician or the physician extender to prescribe antidepressants, but they need to have periods where they stop those depressants, the ones that need levels on, check those levels, and check to see if the behavior has changed. So what do you want your outcome criteria to be? What we have up there for number 1. Patient will not harm themselves. Patient develops a safety plan. Help them. Let them be the center of that care so they can help out with their care, so they can better understand what's going on with them and what we need to do about it. Coping strategies, supportive environment. See what that family environment is. I believe with your patient, the family was not around. Even if they were around, they hadn't accepted what was really going on with this fella. 27 years old. Recognize those warning signs. Patient will be able to verbalize hope and acceptance of life situations that he cannot control. He or she. I don't mean to keep saying he. All right. Safety T is another little graph here that I want you to be familiar with in your suicide assessment. Step evaluation and triage. Identify risk factors. Identify protected factors. Conduct suicide inquiry. Determine risk level and intervention. Make sure that you document. You want to have that documentation done. Okay, families, friends, and caregivers of suicide victims. Just in case, and we're hoping that none of them are, that they are successful, and you have to sort of work with the family. Here is still some few interventions you want to look at. They're gonna have a sense of guilt and responsibility, depending on how close that they are to that relative. They may have a sense of anger and resentment. What did I do? It was my fault. What could I have done to prevent this from happening? They may do it continuously, or they may do it for a period of time and they stop and then it come back. A heightened sense of failure, confusion, why did this happen? A severed strain on a relationship, heightened sense of vulnerability, illness, or disease. Does any of you know anybody or been close to anybody that has attempted or committed suicide? How did that make you feel?
Oh, it still feels awful.
It's awful. Yeah.
Actually, tomorrow marks 2 years. One of my favorite people in the world committed suicide.
Oh, it's definitely got to be a
It's just
loss.
awful.
Yeah.
You
Yeah.
feel guilty. You wonder if you did something.
So you get all those feelings. You wonder if you had got there in time. Maybe you could have saved them.
Well, I had actually had saved him twice before that.
Mm-hmm.
So, but he suffered from clinical depression, and he gave me a much better understanding of suicide than
Okay.
I ever expected. He suffered from serious clinical depression.
Okay.
Birth, basically, and some other imbalances. It was just a matter of when, not if.
Oh, yeah. Wow. Yeah, we can't get into that unpredictability state. All right. So we want to make sure we encourage loved ones. Let them vent. Let them share their feelings. Let them share their memories, whether they're good or whether they're bad. Discourage blame game. No, I'm not going to say bad. I want to say whether they're good or whether they're not so good. I'd rather say it that way. Discourage the blame game from the blaming themselves. Listen to the feelings of guilt and self-persecution. Encourage family members to talk about positive and the negative aspects of the relationship, and identify resources that provide support. And I know y'all said I didn't warn you the last time, but I just love this video. I mean, when I first saw it, I was just looking for videos to show, and it exactly put me in a place where, even though I don't really know anybody that has done it, but it still put me in a place where I felt like I did, and that's why I just love this video.
Dear Nori.
You're out.
Hey Veronica.
Dear Pops.
You were my bestest childhood friend. You were a second mom to me.
You were the best brother.
The whole family tell me we're very similar.
She's like, oh, just like your dad.
We called you Tricky Alex because of all the pranks that you pull on us.
The main entrance to your house was that stairway, and you would always run down, Jessica.
Everybody say you can't dance. And they show me little videos of you. You just be grooving.
Remember when you would scale the walls in the kitchen? And when someone would come around the corner, you'd be there in the middle of the doorway, waiting to surprise us.
You had got us the Mix-a-Lot tape, and we all listened to it in your room, and you opened it, and we were just jamming, having a good time. You have the most beautiful garden. It was a lot of work all the time with me and my friends. If you were here today, I would imagine you still probably volunteering, even with helping the elderly.
I would imagine you would be a doctor.
You would be teaching art, absolutely. I would be in your class.
Going to the library together. I know you like reading. You'll be helping me with my career.
You're just full of energy and a lot of life.
When I found out about your passing, I was at home by myself after school.
Doctor came in and said you were gone.
But I thought you had a heart attack. Towards high school, she told me the truth. She was like, well, your father died. He had overdosed on pills or whatever.
And we were supposed to see each other that weekend. So I broke down in tears, confused, because I had just spoken to you.
And I wanted to physically save you. I wanted to save you. And I didn't really know what to do.
A lot changed. I grieved the law. It was like a complete void at that time.
I just don't understand how you could take a life like that, you know?
Did you think about us? Or maybe you didn't, so it wouldn't change your mind?
There's just so much pain. It's unbearable pain.
I got angry because my best friend, your daughter, changed after that. Until this day, every time I step foot in that house, I still look up those stairs. I still hear your voice.
Your dad is still looking for peace.
I wish you were here today, because there's ways that we still need you. I know I need you, because, like, I'm still a young man. I got a long ways to go.
I wish I knew why we felt the need to just completely leave. Somewhere in the decision-making process, you figured that everyone would be better without you, and that's not true.
You were a good son. You were a good friend. You know you were loved, you feel me? You the heart of the family.
You matter. You always did. You always will.
Alex, you were a little brother. You were full of life and full of energy. You were a good person. I know you're with me every day. Love you, old buddy.
And I love you.
I love you, and I will always treasure our friendship. And for that, I love you. I love you, I love you, I love you.
Okay. Just kind of give you a better understanding of what the family members, friends, loved ones are feeling. So, we're going to take about 10 minutes. We're going to take about 10 minutes to take a little exam, and then we're going to have about maybe 10-minute discussion, and then I'm going to let y'all do evaluations for me, and I know it's still playing. Get it down. And so you can tell me how I did. I love constructive criticisms, and who are the best folks to give us constructive criticism? You guys, because it's going to be what you learned, how you felt, and if you learned anything at all. Again, thank you all so much. Now I'm going to shut this off now. And we'll just take a few minutes to do that.